for basically hypoxemic injury of tissue beds. What we haven't really looked at during this conference is all the information that's out there in terms of CPAP treatments and what it can do for you if it goes on long enough. Over the last decade and more, there have been plenty of data that show at variable length and duration of CPAP treatment, you'll get cardiac remodeling. You can treat hypertension, bring it down to normal values. You can treat inflammation, inflammatory wind-up, if you so will, by variable length of CPAP treatment, and each organ system seems to have a different time as to when it responds. There's actually an older study from the 90s that shows that if you use it for a year or so, your oral space will improve and intubating conditions might be better. So there is data out there, but we haven't figured out how to really take advantage of elective use of CPAP consistently to improve a patient's physiological status before coming to surgery. So same questions that we still have. Does perioperative CPAP improve postoperative outcomes? By that, I don't mean 2 days before. I mean what I was just alluding to, which is you take 8 weeks, maybe 3 months, and what does that do if you consistently use it to improve your physical status? Okay, so the issues that we've seen in these recent studies, I'm still intrigued what's happening in those first 24 hours when you have surgery and you acutely recover. What are we seeing there, and what is it that we don't understand yet? It seems like a lot. Again, the OSA-ASI guidelines, I mean, as far as I can tell, no one has really adopted them. In my mind, I'll be blunt. I mean, I think, unfortunately, they've been fairly useless other than making us all aware that there is an issue there. But they haven't really given us any tools how to deal with it in a consistent way. My personal bias is to almost say, well, you know, can't they come out with a statement that says, we don't really know yet, but it's there, be careful, develop your own institutional guidelines that fit how you practice, and when we know more, we can give you something that's actually evidence-informed rather than expert opinion that then nobody after a while listens to. So maybe that's a little far-reaching what I'm saying, a little aggressive, but I think sort of that's where we are. And then Girish came out with basically pointing to why we needed new OSA guidelines and what kind of tools we might be able to use to improve patient care with OSA in the perioperative environment. As far as the outpatient surgery debate is concerned, so thankfully there was a lap band epidemic in the past, because a lot of those studies were actually done in patients who received lap bands to look at, you know, can we safely do this on an outpatient basis? And what's the role of sleep-disordered breathing? And of course, it's always obstructive sleep apnea in this group of patients. And most of these patients are, or actually some of them are retrospective, some of them are prospective. The general gist of it was it's probably doable under certain conditions. And here are the suggested conditions as to when you might be able to use it. But again, this was lap bands. This was nothing more invasive than that. It should only happen in the framework of a longitudinal bariatric treatment program. So in other words, somebody showing up, I want my lap band, and then go home and not do anything, is probably not a very safe thing to do. Comorbid conditions should be optimized. There should be standard sleep disordered breathing screening for these, and if they are screen positive, they should probably be referred to find out how bad it is. And it seems like there's a fair consensus that appropriately treated sleep disordered breathing before bariatric surgery, it should be a base condition for those patients to go forward. Post-op use of CPAP as indicated. And one of the big things is implementation of standardized surgical and anesthetic perioperative bariatric clinical care pathways. So the whole concept of pathways and doing standardized care is important in that context. And last but not least, there needs to be a home structure to release a patient into, particularly for those with sleep disordered breathing. You want to have someone at home for them if they leave, to make sure there's somebody else in the house. At the very tail end, we also heard a little bit of talk yesterday about the whole issue of inflammation and how there is an interlink between sleep disordered breathing and inflammation and inflammatory markers, and that's a nascent territory. And of course, OSA and obesity overlap to a large degree. I mean, they're both inflammatory conditions, and they both have similar markers. Here, just some data on IL-6, TNF-alpha, and CRP. All those three are cytokines that you can look at in both obesity and OSA. And out of there, one of the questions is, does sleep disordered breathing have an identifiable and unique inflammatory signal? What is it, if so, and can it be modulated? Does it make sense to do so to affect outcomes? And where's our role in terms of anesthesia in influencing perioperative acute phase immune modulation in these patients? That's a nascent territory, I think, that could be very fruitful to look at, including the question, well, if there is an inflammatory response, is it actually good or bad? And is there a threshold where the good starts being bad? In summary, what we've just briefly talked about, lap sleeves have really become a big piece of the surgical care now in bariatrics, and lap bands have gone down dramatically. I think there's pretty much the take out there among surgeons that it doesn't work very well. Obstructive sleep apnea is still the best investigated sleep disordered breathing entity in the obese population and still remains underdiagnosed. Complications in sleep disordered breathing postoperatively are significant, and some of these outcomes that I showed you and that we are being made aware during this conference are sort of hard to reconcile, and whether they're study related or there are true signals is something that remains to be determined. But I think there's something there that should stir us to be more inquisitive and do the right studies, or find something that helps us with determining how to better classify patients for their risk in the context of OSA. And that's what I have for you today. Thank you very much for your patience.
We'll take questions at the end of the session. So our next speaker is Dr. Robert Farney. Dr. Farney is Adjunct Associate Professor of Medicine at the University of Utah Health Sciences in Salt Lake City, Utah. He's also the Chief of Sleep Medicine Division at the Intermountain Sleep Disorder Center in Salt Lake City, as well as the Director at the Intermountain City. He has helped me a lot with respect to the newsletter. I'm sure you've seen his articles in the newsletter. And he's going to talk to us about this new problem which we have with Suboxone. And those who have come across these patients, it is becoming very popular, and he's going to speak on Suboxone and sleep disordered breathing, or look out for the low ceiling. Thanks, Dr. Farney.
Can I switch?
Sure. Do you have the connector? Once you put your stuff here. Detect. Go into detectors, settings. There you go. You got it. Yeah.
Well, I'd like to thank the committee for inviting me here and giving me the opportunity to give this presentation. I really have just a really simple statement and message, which is that we are seeing a drug that's an old drug make a resurgence, and no matter what you're doing, you're going to encounter people who are on this drug, buprenorphine or Suboxone. It's been used much more widely in Europe, but it is increasingly used in this country as well. And despite the fact that it's reported to be more safe because of a ceiling effect on its toxicity, it is probably more safe, but there are also some very significant potential problems with it. So this is my disclosure slide, and it's pretty embarrassing, and the closer I get to retirement, I'm pretty open to some possibilities of having some conflicts of interest. I also noticed that from the back of the room, it's sometimes hard to see some of the numbers. So I made this slide a minute ago, and I also animated it. So that's all the numbers for the back of the room, folks. And maybe there's something significant about what I've got to tell you, but let's go ahead with the rest of the slides. So this is a slide from the Salt Lake Tribune. I think it was 2007 or 2006. Bride died on her wedding night. She had been using methadone and fell back. This is not patient 0, but she's maybe 1,000 or something before this. But it really gets your attention when you see something like this, and we've all had these sentinel types of experiences. Todd Gray is the medical examiner in Salt Lake City who became quite interested in this, and when I saw this come out in the newspaper and it sort of paralleled some of the stuff that we were doing, it really got me very, very, very interested. This was in 2005. His idea was that people who have obstructive sleep apnea are likely more vulnerable to complications of opioids. And so he was really interested in trying to figure out if there was a problem for what he identified was this chart. Does this work, by the way? Which shows a dramatic increase in the death rates due to poisoning deaths about 1997 compared to the years before that. And so he looked at the details of why these people were dying, and at the same time we have this data from ARCOS showing the increasing prescription rate for methadone in Utah, which is in the purple bar compared to the United States in the green bar, so Utah is way ahead of the rest of the country. This is up to 2003. And the total number of deaths in that first part was from 1991 to 1998, the death rate was 1.47 per 100,000. In the second half of that, the death rate increased to 4.4 per 100,000. That's a 200% increase. And that parallels the prescription rate for methadone, which went from 2.3 up to or the death rate rather for methadone went from 2.3 to 32.7, or over 1,000% increase in the death rate just due to methadone. But it was also true for oxycodone, hydrocodone, and all the other opioids. When you look at the demographics, the females actually increased 261%, more so than the males. The absolute death rate was more in the males than the females, but the death rate increased greater in the females. And if you look at the body weight, yes, those who were obese had a death rate of 6.1 going to 14 in that time, so they did increase, but compared to the thin, non-obese female, the death rate increased 208%. A later study, this is from 1999 to 2008, basically captures the same type of data. This was for the entire United States. There were 36,000 deaths related to drug overdoses, of which 74% appear to be related to opioids. And the statement was made, the epidemic of overdoses of opioid pain relievers has continued to worsen. The worsening of the death rate parallels the sales of the various narcotics and parallels the admissions for opioid overdose. This graph on the left shows the usage or the prescriptions of opioids sold in 2010. The black and the dark blue are those which have the greatest amount. Buprenorphine is not included in that data. The graph on the right shows the death rates in 2008. So again, Utah is way out there. The breadbasket of the country is pretty holy and not having as much problem except for Oklahoma. And this shows from that national survey, the death rate in the 2008 compared to the previous data by Todd Gray was about the same. And the demographics, when you look at them in further detail, also show the same thing. The association of sleep-disordered breathing and opioids, and despite the fact that we've known for centuries about the potential problem, but the possibility that something was going on in sleep and central apneas was really unrecognized until around 2001, 2003, when this data was published from Australia showing the presence of central apneas in a methadone clinic. And I guess I should comment on an adage, and I don't know how widely known this adage is, but it goes something like this, that even a blind sow now and again finds an acorn. In my case, it's usually a pebble or a little rock, or sometimes it's just a turd. But I actually came across something pretty much by accident, which was the association of some unusual breathing patterns in patients who'd been on opioids. And it had puzzled me for years before this in seeing this. Well, this was one of our patients who had been previously treated effectively with CPAP on a pressure of 15 or so, and for various reasons ended up being on opioids. And what you see are a lot of central apneas during non-REM sleep and relative stability of breathing in REM sleep on the right side of the graph, and a failure to respond to the previously effective dose of CPAP. We also saw this pattern, which is clearly ataxic or BIOTS or BIOS, however it should be pronounced, showing in actually a thin woman who was on opioids. This is 300 seconds, and it shows very clearly this ataxic breathing pattern with variability of respiratory rate and volume. This is a picture from a very old textbook of mine of physical diagnosis. I had seen that about 100 years ago, did not know what it meant, but it always stuck in my brain. And so this is a tracing by Bio showing ataxic breathing with variability in a young person with tuberculous meningitis. And there was this description: this irregularity of the respiratory movement is not periodic, sometimes slow, sometimes rapid, sometimes superficial, sometimes deep, but without any constant relation of succession between the two types, with pauses following irregular intervals preceded by a sigh more or less prolonged, and very similar to a pattern of atrial fibrillation. This is my slide to challenge the people in the very back of the room, but on the top is an example of what was called non-periodic breathing, in which you really see ataxia, and in the bottom you see cluster type breathing, or excuse me, periodic kind of breathing, mainly with central apneas. So we look retrospectively at the chronic opioid use and as a risk factor for having central apneas and ataxic breathing, and found that yes, those who were on opioids had a significantly higher apnea-hypopnea index than the non-opioid matched controls, 43 versus 30, and the main difference was central apneas. And unlike the obstructive apneas, who tend to be more obese, those with the central apneas and apnea-hypopnea indexes increase mainly to the centrals, it was more often seen in the thin. So the BMI is the blue of 16 to 28 BMI, and the red is the obese, 32 to 55, so that you see in the obese patients, you're more likely to be it's the non-obese patients, rather, that are more likely to have apneas with opioids. This is an example of a couple of these patients. The matched controls on the top is a 32-year-old female with a morphine dose equivalent of 375 milligrams, non-obese, 22 BMI, versus a similar female not on opioids. And two people referred in for the possibility of sleep apnea. And so you can see the ataxic breathing on the top. This shows the same patient with room air breathing on the top and oxygen breathing on the bottom. So I think in some cases, actually, oxygen breathing does seem to have some effect, but often not very dramatic. I think you can see a lot of irregularity of the breathing pattern in room air as well as oxygen. This is for the non-anesthesiologists who don't have any familiarity with buprenorphine, but this I think needs a little bit of explanation as to what this drug is, because it's a very unique and very interesting drug. So the first use of, or the first reference, I should say, to this compound may have been in the 3rd century BC, the opium plant derived from the Greek word for juice. And this shows that from that milky substance, we get alkaloids, morphine, codeine, and thebaine, and it's this, which is only about 0.2% compared to 10% for morphine, from which we get semi-synthetic opioids like oxycodone and buprenorphine and naloxone are all synthesized from that compound. And so it represents the full range from naloxone, an antagonist, to a full agonist methadone or oxycodone with buprenorphine in between. And you can see that it is a partial mu agonist because it seems to have a ceiling effect in terms of its opioid respiratory effects. So buprenorphine has become widely used for therapy of opioid dependency because of its unique pharmacologic properties and apparent more favorable safety profile. It's a partial mu agonist. It has a potency 25 to 50 times greater than morphine. It has a high receptor affinity, 1,000 times greater than morphine. It has a long dissociation half-life, and it has a ceiling effect in terms of respiratory suppression. So you have an agent which is highly potent, that sticks like glue to the mu receptor, but it has a ceiling effect. This is some data showing why it's believed to behave this way. The graph on the left is fentanyl, the one on the right is buprenorphine. On the y-axis is a reflection of ventilation at peak effect of the drug, and on the horizontal axis is drug dose. So as fentanyl drug dose is increasing, you see in the continuously decreased ventilation compared to the graph on the right with buprenorphine, where you see some decrease in ventilatory response, and as the drug is higher doses are used, you have a flat response, so that there doesn't seem to be further ventilatory suppression with increasing the dose. This is another study contrasting the analgesic effect with the respiratory responses. The graph on the left shows 2 doses of buprenorphine. The dark dots are the small dose, 0.2 milligrams compared to 0.4 milligrams in the open circles, showing that as you give the higher dose, there's really no significant difference in the ventilatory suppression compared to the analgesia. So on the right graph, you see the higher dose seems to have a greater biologic effect in terms of analgesia. So this is a cool thing because you can give more drug and it seems to be more effective for analgesia, but it has a flat response for respiratory effect. And in fact, in some cases, it may even be U-shaped, so that the more drug you give, the even less effect that there may be present. And some very clever drug addicts have actually used Suboxone in their friends when they find somebody who's had an overdose and will inject them when they're unconscious with buprenorphine to reverse them, just like naloxone. So those are some of the studies that indicate why this drug might be more safe. This is from data from France. The blue line shows the heroin overdoses. The green boxes show the patients given buprenorphine, and what you can't see on the bottom is almost invisible, is the ones who were given methadone. There's been a very slight increase in methadone use, a huge increase in buprenorphine, and there seems to be a marked reduction in heroin overdoses. So at least in this situation, there seems to be some validity to the safety of this drug. Now in this country, I guess maybe they're open, I don't know if they're working these days or not, but this is from the Drug Enforcement Administration, the Office of Diversion Control Program. They collect drug identification results, associated information from drug cases, analyzed by the federal, state, and local forensic laboratories. I don't know if you can see their website down there below, www.nflis, and then I think it says dediversion. So I'm showing you some interesting data from this, and it's actually a very interesting little special report to look at. And this shows the increase in methadone prescriptions by thousands. In the green line, and the orange line shows buprenorphine increasing up to 2008. So you can see that while methadone has increased, at least up until then, buprenorphine is skyrocketing. This shows the states, and the very light green, you can see the big one there is Utah. So this was in 2003 to 2008. And there's a few other states up there in the northeast corner. I don't know any of those states over there, but there's a couple of them. And then in 2008, we now see on the right increasing prescriptions for buprenorphine, and that dark blue is Utah, and there's Kentucky over there. So you can see that in this time frame, the prescription rate for this drug has increased dramatically. This graph illustrates two things. There's the green line and the orange line. The green line is the buprenorphine distribution, how much is being provided. And it's gone from 107 grams in 2002 to 800,000 grams in 2008. That's a 7,000% increase in buprenorphine prescriptions. And I think 6,500% are in the state of Utah. So this has provided us a huge opportunity. I think they're on one floor, actually, of our hospital. And items, I think, refers to police activity confiscating drug paraphernalia. So that's gone up 250% related to this drug. So this got us interested in this drug because the psychiatrists didn't think that there was a problem at all. And they were pretty surprised when we suggested that, you know, we've been seeing some of these patients that look like our other patients that are taking methadone and stuff, and they really didn't believe us. But we got together, and the psychiatrists worked with us, so we couldn't predict who would get this reaction, and so we made a decision to implement a care process model in which we basically just started studying everybody who was being admitted for detoxification with Suboxone. We couldn't depend upon risk factors because we didn't know if there were any risk factors. So we just started doing routine inpatient polysomnography on these patients. So all patients who were admitted for opioid detoxification were seen by sleep medicine. There was no selection criteria. We did all the standard measurements, demographic data, stop bang questionnaire. They had comprehensive polysomnography 24 to 48 hours after beginning Suboxone. So this drug is given after you've been in the withdrawal stage, so that theoretically the effect of whatever they were taking before, usually heroin and OxyContin, have diminished. And then we analyzed the respiratory abnormalities in these three domains. And we've been talking about the AHI and how that doesn't always describe everything. I actually think that the domains that I'm showing on this slide is very helpful for me, because you may see one or all three of these abnormalities in somebody. Obviously, apnea-hypopneas with central or obstructive apneas, or hypoxemia, or abnormality of the underlying breathing pattern, whether it's ataxic or whether it's regular. And I think that you can look at the effect of these drugs by looking at these particular domains. So this is an example of what we called, or what's called BIATS breathing, and we had no way of deciding, whether it's mild, moderate, or severe, so we just sort of arbitrarily made this up and published that in an article regarding adaptive servo ventilation. And on the top is very, very minimal, slightly irregular ataxic breathing, which we can see a lot, and I don't know whether it means much, but you can see it, compared to on the bottom, which you see is cluster breathing. And if you go back and you look at the original articles or the articles that have been published talking about BIATS respiration, they're often talking about this cluster breathing that you see on the bottom, although BIATS' original article was more ataxia. So the methodology in terms of our analysis, standard stuff, and then we used something called a random forest analysis, which basically constructs various decision trees to assess whether there's a relationship between various factors. This summarizes the patient characteristics. They were young, mean age 31.8, thin, BMI 25, Mallampati scores 2.7, stop bang score about 2.7, and their average Suboxone dose was 18. The target, by the way, is around 16 milligrams per day. And this shows that the apnea-hypopnea index, that for moderate 15 to 30 AHI and severe over 30 per hour, was about, well, you can see 16% for moderate and 17% for severe. 37% did not have any obvious apnea-hypopnea problem. The overall for the group, AHI was 20, of which the majority of events were central. The baseline, and we are at 1,500 meters or 4,500 feet in Salt Lake City, so the baseline oxygen saturation about 92%, the lowest 84%. The time below 90% is, average is 23%. This shows, I want to show just a couple of cases that show you what we're seeing. A 62-year-old female, BMI is 20. The histogram on the top is typical for opioids, where you see almost uninterrupted, sustained stage 2 non-REM. And the middle graph shows you the oxygen saturation pattern to begin with on room air, and then oxygen is added. And the part on the bottom with the red shows the central apnea index of 84.7. This is a sample of the raw data, 5 minutes, and you can see obvious cluster breathing and oxygen desaturations. Here is a 23-year-old female cigarette smoker after 10 milligrams of Suboxone, and notice the sleep histogram on the top. When we see a sleep pattern like that, we don't even have to look and see what the medication record is. They're almost always on opioids, and typically Seroquel and Neurontin, but almost always on opioids. And then you see on the bottom the red marks showing central apneas. This woman had a respiratory arrest actually after beginning Suboxone. This is an example of her raw data showing you the ataxic breathing pattern. I don't know how you classify these. They're very difficult to score, these people. They don't fit the regular criteria. Here's a very common scenario, 53-year-old male, 14 milligrams of Suboxone, and he has mild irregularities throughout his oxygen saturation pattern and mild sleep-disordered breathing according to the usual criteria, and this is his raw data. So there's something obviously pretty wrong with that, regardless of the AHI. So looking at the random forest model to try and see, well, how can we predict? Is there some way you can anticipate who might have this problem? And we looked at all those predictor variables on the left, the dose, the individual stop bang indicators, the benzodiazepines, which has been noted over and over and over again in buprenorphine doses. Oh, it doesn't happen unless you are abusing it, you shoot it IV, or you take a benzo with it. And in this study, as well as the previous study of ours, we did not see a clear relationship between benzos, antidepressants, antipsychotics, or cigarette smoking with any of those responses in the right. This shows a density plot, and we have like 100 of these, This is the apnea-hypopnea index with benzodiazepine. So the blue line are individuals just taking buprenorphine, and the magenta line represents people taking buprenorphine and a benzo. And if there was a big difference, you'd expect those spikes to be different. You would expect that if you're taking a benzo, that magenta peak would be far off to the right, showing that there's some sort of an association there. This is with cigarette smoking. This is the lowest SpO2 by smoking history. And it looks like, if anything, smoking cigarettes, you're less likely to have a problem in terms of the lowest SpO2, or the percent time that your oxygen saturation measured less than 90%. So conclusions: despite the protective ceiling effect, there are potential problems. Buprenorphine is a potent drug below the ceiling. So below the ceiling, it's still a very potent opioid. So 16 milligrams of Suboxone is equivalent to 60 milligrams of methadone. And we've demonstrated that it certainly has the potential in some individuals of causing sleep apnea. If we look at the therapeutic index, conventionally, the red line, for example, shows you the dose response and effect, biologic effect of a good response, of, say, for example, lowering of blood pressure, and the effective dose is 0.4, and the toxicity of this particular drug might be 40 for toxicity. But you know, all these drugs are tested in the awake state. Data is not accumulated in sleep. And so in the state of sleep, the toxicity and the effective dose for toxicity may be very much lower than, it may be close to its therapeutic dose. There is no correlation that we could see between the buprenorphine dose, unlike other opioids, and we did not see a clear relationship between benzos or other drugs that have been implicated as being a problem. So with that, I will close and just comment that I think buprenorphine possibly is a safer drug. There's a lot of individual differences, and I think we'll just see how it plays out in the future. Thank you very much.
Thank you. Set up. So our next speaker is Anthony Tufus. He's associate professor in the Department of Anesthesiology, Perioperative and Pain Medicine at Stanford University School of Medicine, Stanford, California. And he's going to speak to us on pain management with opioids in the postoperative period and the impact on sleep-disordered breathing. Thank you, Dr.
Thank you, Juris. Thank you very much for this invitation to talk here today. After all these wonderful lectures, my presentation will be rather trying to stimulate some thoughts and discussion around the possible links between opioid pharmacology and the pathophysiology of obstructive sleep apnea. Unfortunately, the evidence we have regarding the links between opioid analgesia and sleep disorder breathing in the perioperative patient or postoperative patient is very sketchy and very, very weak. So opioids are very important drugs. We use them every day to treat moderate to severe pain in the postoperative patient. They invariably cause, and dose-dependently, cause ventilatory depression. With the term ventilatory depression, I mean central respiratory depression, sedation, and possible airway collapse at high doses. This particular endpoint may be especially important when we're talking about obstructive sleep apnea. So hypoventilation, depending on how we measure ventilatory depression in the, can you hear me? Oh. Sorry, okay, thank you very much. All right, depending how we measure this ventilatory depression, either by hypoventilation, hypercarbia, low respiratory rate, or arterial desaturation, the rate ranges between 1 and 17%. And these are data from large patient registries or retrospective case reviews. Events that are really requiring intervention, meaning a reversal with naloxone, endotracheal intubation, or cardiopulmonary resuscitation, are quite rare, probably less than 2%. There is probably a high-risk window in the first 24 hours after surgery. And this actually, the Babak presented some data some time ago that there is a high-risk window for endotracheal intubation in obstructive sleep apnea patients, and that was also at the first 24 hours after surgery. So this quite fits with that picture. So are obstructive sleep apnea patients more prone to the opioid, to ventilatory depressant effect of opioids? There is some correlation in the literature between several comorbidities and critical respiratory events after surgery, meaning coronary artery disease, congestive heart failure, renal failure, COPD, diabetes, obesity, and obstructive sleep apnea. Dr. Ahmadrjan actually published a paper in 2011 looking at the large patient registry from Michigan University Medical Center, examining, it was a targeted search in a big database looking especially for life-threatening critical respiratory events defined by the need for reversal with naloxone, intervention with endotracheal intubation, or with cardiopulmonary resuscitation. Among 86,000 patients, he identified 32 such events. 4 of these events had a fatal outcome. A common pattern for these fatal outcomes was nocturnal occurrence and heavy sedation. So patients were heavily sedated before they died, the last time they were checked. Also, he found that coronary artery disease, congestive heart failure, and obstructive sleep apnea and acute postoperative renal failure were among the comorbidities with high prevalence, higher prevalence than the baseline prevalence for these comorbidities in the rest of the database for those 32 respiratory events. So after Dr. Horner's lecture, I feel kind of embarrassed, actually. Don't hear me?
Yeah,
Oh, I need to speak up. All right, sorry. Okay, presenting the different non-analgesic actions of the opioids, which basically the depression of the central respiratory drive, acting both on the pre-Bondiger nucleus and as a result lowering the respiratory rate, causing irregular respiratory rate and a low tidal volume, and of course, sorry, what's going on? Oops. All right, here we are. And of course, direct depression of the hypoglossal neuron motor pool. Also, they act both, sorry, I have here somewhere. They act both peripherally in the carotid bodies and centrally in the brainstem to depress the response of the ventilatory system to both hypercapnic and hypoxic challenges. This particular effect is potentiated by sleep, and some experimental studies in humans have shown that it's partly reversed by painful stimuli. Also, is partly reversed by audiovisual stimulation that requires the active participation of the patient. Of course, opioids also cause sedation. They inhibit what we call behavioral control of breathing. All right? They make you unaware that you need to breathe. All right? And they cause sleep disturbance by several neurochemical changes in the brain associated with decreased cholinergic transmission, decreased inhibiting orexinergic neurons, and also adenosine concentration. These effects on sleep actually have been implicated in causing some state of, potentially causing, we don't know for sure, some state of hyperalgesia, which means that through this effect, opioids may counteract their analgesic effects. Now, the function of the normal airway depends on the balance between forces that are trying to collapse the airway, like during normal breathing, the drop in the pressure inside the airway because of the action of the negative pressure generated by the diaphragm, and external pharyngeal pressure by parapharyngeal tissue. Now, when we take a deep breath, immediately there is a coactivation of the dilator muscles by the respiratory neurons mediated by central pathways, and of course the wakefulness drive also participates to that. As well, there is a local, what we call local airway splinting reflex in order to keep the airway open and withstand the negative pressure which is exerted or generated by the diaphragm, the respiratory pump muscles. Now, opioids eliminate or partially eliminate, the wakefulness drive, depending on how much you give to the patient. And of course, they inhibit the respiratory neurons, both centrally and specifically the hypoglossal neurons, as Dr. Horan showed very well this morning in his presentation. So the logical result of this will be a tendency of airway to collapse under the effects of opioids. Now, obstructive sleep apnea is characterized by an anatomically impaired airway, anatomically narrower airway. But the severity of obstructive sleep apnea is probably determined rather by the quality of the compensatory mechanism that the system develops to deal with this anatomical defect than by the anatomical defect per se. So that may have some importance in the effect of opioids on the airway of obstructive sleep apnea patients. Now, in the horizontal axis, you have dose or effect site concentration of opioids. On the vertical axis, the y-axis, you have the opioid effect. So we have the dose response curves for various endpoints or effects of opioids, which meaning analgesia, respiratory depression, sedation, and airway collapsibility, cumulatively called opioid-induced ventilatory impairment. This actually doesn't exist. This is the holy grail of opioid pharmacology, which means you get done with the maximum analgesic effect, and you still have room to go before you enter the zone of badness, respiratory depression, sedation, and airway collapsibility, which can interact among themselves to present a patient with what we call ventilatory depression. Actually, this study is one of its kind. Dr. Dahan published this in 2004 in Anesthesiology. It's an experimental model in 8 healthy volunteers. He used an experimental model of pain to determine analgesia, morphing analgesia, and at the same time, simultaneous modeling of the analgesic depression of the respiration, which was measured by depression of the hypoxic ventilatory response, isocapnic hypoxia in particular, in those 6 patients under 3 different dosing schemes of morphine. One was bolus, then bolus and infusion, and then multiple boluses. Bolus first, and then multiple boluses every 6 hours. So that was the first study, as far as I'm aware, to show in humans that analgesia and respiration depression was actually somehow were coming from the same structures or from neighboring structures in the brainstem, brainstem and supraspinal centers, and that the time course of those that they were both originated by mu opioid receptor effect. So you see here, she managed to show similar morphing sensitivities for those systems involved in opioid-induced analgesia and respiratory effect. You can see though in these two curves, which basically concentration response curves for analgesia and respiratory depression. The ED50 or C50 for both of those effects are about the same level. And they have some slight difference in terms of what we call the shape of curve, which the authors discuss this in their paper. It may be an effect of the fact that volunteers were conscious. Maybe there was a direct effect on consciousness on pain and analgesia mechanisms. So that's a problematic patient. In order to buy analgesia, actually the green analgesia curve should be a little bit closer to the respiratory depression because you have this almost at the same time. In order to buy analgesia in patients, you need to have the respiratory depression and sedation. We don't know yet much about the airway collapsibility, even in normal people or in obstructive sleep apnea patients. So let's try to examine first, is there any way to understand better, can we pharmacologically separate those curves and move this analgesia curve to the left and move all the bad outcomes to the right so we can make some space between them, so we can have more room to give in order to achieve effective analgesia to our patients without ventilatory depression. First of all, do we know anything about the sensitivity to pain in obstructive sleep apnea patients? Are they more sensitive to pain? Important pathophysiological components of OSA, which are basically landmarks of the physiology of the disease, fragmented disrupted sleep, and chronic intermittent hypoxia, have been implicated by studies that I will show you in a minute. That increase sensitivity to pain. For example, fragmented or inadequate sleep cause hyperalgesia. They cause inflammation, and through inflammation can also cause hyperalgesia in volunteers. We managed to show in a set of about 600 patients from the Cleveland Family Study that chronic intermittent hypoxia indicated by average and minimum saturation during sleep was independently associated with pain in these individuals, independently of sleep fragmentation and inflammatory cytokines. And of course, inflammatory cytokines are encountered in OSA and are hyperalgesic, IL-6, TNF, IL-1 beta, in several hyperalgesic in several animal models. Now, the application of positive airway pressure in volunteers with obstructive sleep apnea for 1 week depressed the sensitivity to pain in those patients. The only study that goes the other way was that by Michael Smith from Johns Hopkins, who found that in chronic pain patients suffering from temporomandibular disorder disease, the presence of obstructive sleep apnea in those patients was associated with hypoalgesia, they were less sensitive to a specific mechanical pain, model of mechanical pain, experimental. That was an experimental study. So this is the study that is going to come out in November. We gathered some data, actually, we applied to have access in the Cleveland Family Study through NIH, the database for genotype and phenotype, which are actually publicly available now. But you need to go and apply with your hypothesis and an analysis plan to study this prospective hypothesis that intermittent hypoxia predicts pain. So we had 634 adults with pain reporting for 3 types of pains, like headache during sleep, headache that disrupts sleep, morning headaches, any pain that disrupts sleep. And one more pain that I don't recall right now, everything is in here. So what we found is that minimum saturation during polysomnography was independently associated with increased odds for pain reporting. This is a pain composite. We took all the pains together and we constructed a composite pain score. If you see here, we have a model. We adjusted the model for clinical phenotypes, BMI, gender, etc. And also, we added a third adjustment, adjusting by sleep fragmentation. We did principal component analysis for several measures of fragmentation of sleep, arousals, etc. And inflammation. We had in our availability 5 different inflammatory cytokines. So we used them also to adjust the model. And despite all these adjustments, hypoxia during sleep was associated with increased odds for pain reporting. Now, this odd ratio presents the effect of one standard deviation in our distribution. To put this in clinical perspective, we did a comparison between the second and third quartile of our distribution and found that a decrease of saturation from 92 to 75%, which is pretty frequent in obstructive sleep apnea patients, was associated with a doubling in the odds ratio for pain reporting. Now, these data are not probably directly applicable to perioperative patients, but they may signify that intermittent hypoxia might be associated with an increased sensitivity to a painful stimulus. What about opioid analgesic sensitivity in obstructive sleep apnea? We all know by now the study by Karen Brown, and also some additional animal studies by Laferriere, showing that in children undergoing adenocolectomy, recurrent nocturnal hypoxemia was associated with a decreased analgesic consumption, a decreased morphine consumption for postoperative pain treatment. She did the study in 22 children. It was a prospective experiment. 22 children. She used nocturnal oximetry, not polysomnography. And the preoperative lowest saturation, less than 85%, compared to 85 and higher, was associated with a decreased morphine by half in terms of pain relief in these young patients. Now, these findings were backed up by independent experiments in animals by Laferriere, who showed that there was an upregulation of mu-opioid receptors by terminal hypoxia in developing rats, an animal model. We tried to replicate the findings by Karen Brown in adults. So what we did is we called people who were high risk for obstructive sleep apnea, and we asked them to go and attending polysomnography overnight, and a week after that, we called them into the lab where we administered some experimental pain tests. We tested them for experimental heat and cold pain, and we evaluated the threshold and tolerances for those pain stimuli. We got a blood sample in the beginning to measure some hypoxia-related biomarkers, like VEGF, EPO, and this one, which is the insulin growth factor binding protein 1. So what we did actually, we test them for pain at baseline, placebo, and at two randomized order, two different target effect site concentrations of remifentanil. So we found that there was a significant association between the lowest SpO2 in the polysomnography and the opioid analgesia that this patient gets. So the lowest the oxygen, the more sensitive they were to the analgesic effect of remifentanil. And analgesia in this case, we mean how far up the threshold or the tolerance of those experimental pains were after the start of the infusion. Now, this is a very informative graph, actually. When I saw it the first time, I said, oh, that's very complicated. But it's not. Now, let's talk about a little bit what it happens to obstructive sleep apnea patients. 2 minutes? Oh, no way. Okay. All right, thank you. So, basically, you see the chemical, the dilator activity, the activity in the dilator muscles of the upper airway, how it changes as the chemical drive increases after a person falls asleep from awake to the sleep state and the airway collapses. All right? So you see the chemical drive, which means hypercapnia, hypoxia, rises up to a point which is called the recruitment threshold. At this point, the dilator muscles start to responding to this increased chemical drive. They respond up to a point which is called effective recruitment threshold. At this point, there is an opening of the airway. So at this opening of the airway, for 2 to 3 breaths after this point, the patient still very robustly hyperventilates. And this is because there is an obligatory delay in the gas between lung and the central or carotid bodies, chemosensors. So because of this